Thank you. Welcome everyone to
দাঁড়াও
this.
একটু জাস্ট মিনিট দেখি ওরা রেডি কিনা, কারণ ফেসবুক লাইভে
Oh,
সরি
sure.
আমি বলতে ভুলে গেছি।
Yes, sir. আমরা ফেসবুকে লাইভ আছি। থ্যাংক ইউ।
হ্যাঁ ঠিক আছে, তাহলে এখন শুরু করো আদনান।
Sure. Okay. Welcome everyone to this edition of PHA's talk on heart failure. We are extremely grateful and lucky to have esteemed panel of specialists today to join our discussion. I would like to welcome them all. And at this point, I would like to welcome Dr. Farzana Haq to present. Before she starts, a brief overview of her credentials and her experience here. She's a well-known physician with the St. Louis community and actually in the internal medicine community here as well. She is an associate professor of internal medicine in the Division of Hospital Medicine and the co-director of the internship at St. Louis University in St. Louis. She also serves as an inaugural medical director of Bordley Tower at SSM Health at St. Louis University Hospital. She is a recipient of numerous awards, including the Caring Physician Award and the Attending of the Quarter Award, as well as the Excellence in Professionalism Award from St. Louis University. She also received the Clinical Award Physician of the Year by SSM Health, representing the solo physician selected from all hospitals in St. Louis, Missouri. She's also been recognized as a 40 under 40 honoree by the St. Louis Business Journal and the Unsung Hero by the Society of Hospital Medicine. The American College of Physicians has selected Dr. Haq to receive the Young Achiever Award for 3 consecutive years. She has been invited as a speaker at regional, national, and international conferences all over the country and has over 40 publications. She is currently the president of the Society of Hospital Medicine's St. Louis chapter. She's also a fellow of the Royal College of Physicians of UK and a deputy editor of the Bangladesh Medical Association of North America. And at this point, I would also love to introduce our esteemed panelist. We are grateful to have Dr. Chaudhry Ahsan, one of the trustees of PIA and the clinical professor of medicine at Cardiovascular Research University Medical Center in Las Vegas. We also have Dr. Nasir Khan, trustee of PHA, and he is currently director of the Structural Heart Program in Methodist Dallas. We have Dr. M.A. Sattar, professor and head of Department of Medicine at Chittagong Medical College. We're also lucky to have Professor Dr. Muhammad Abdul Kalam Azad, chairman of Internal Medicine Department in Bangladesh Sheikh Mujib Medical University. We have Dr. Muhammad Rafiqul Islam, professor of medicine at Shoaib Sohrawardi Medical College. And lastly, we have Professor Dr. Shafiqul Bari, professor of internal medicine at Dhaka Medical College. So we have plethora of experience and expertise today at this special talk. And without further ado, I'm going to request Dr. Haq to begin.
Thank you so much, Dr. Chaudhry, for your generous introduction. It's truly a tremendous honor and privilege to give this talk to this brilliant audience. Many of the panelists, I know from the beginning of my residency, and over the years, I'm so much grateful that I have learned from their wisdom and expertise. So in this talk, we will take a journey together where we will focus on evidence-based guideline-directed medical therapy, GDMT, for heart failure management. Secondly, we will learn what are the practical and actionable strategies to optimize patient care, both for inpatient and outpatient settings. And finally, we will focus on crucial aspects. What are the beyond guideline-directed medical therapy to amplify our patient outcomes? So let's see what will be the roadmap of this session. First and foremost, we will briefly have the overview of heart failure epidemic and impact. Secondly, we will explore 2022 SEC, AHA, and HFSA guidelines for heart failure management. Under this section, we will focus on key learning points for both inpatient and outpatient. In this section, we will also solve a couple of clinical cases, and those closely resemble to our daily practice we see almost every day in our setting. And finally, beyond guideline-directed medical therapy or GDMT, we will focus on the strategies to optimize the heart failure management for our patients. I believe one of the biggest goal of this talk is to keep it concise so that we have enough time during our Q&A session to learn from each other, most importantly, to learn from our brilliant panelists as well as from our audience. So let's begin. First, we will focus on briefly what are the heart failure epidemic and impact. Heart failure is a global issue. As you can see in this graph, almost all the region of the world has patients of heart failure. So regardless whether we practice in Bangladesh, US, or UK, all of us know that high yield, this is a high yield topic and practical topics, and truly deeply important for all of our patients. Heart failure, this is a public health emergency. As you can see from this image that a significant number of hospitalization, healthcare cost, mortality happen due to heart failure. Strikingly, mortality risk of heart failure go higher after each subsequent heart failure hospitalization. As you can see from this graph, that heart failure mortality is significantly higher than many of the cancers. Average lifespan is 5 years and mortality rate increase after each hospitalization. I believe as clinician, this is our responsibility to inform and to educate our patients about this high mortality risk. For example, when a patient gets diagnosed with cancer, they are very much concerned about their health and they try to do everything to survive. In contrast, when a patient gets diagnosed with heart failure, neither the patient nor the patient's family take it very seriously. That could be one of the key reasons of lack of adherence on guideline-directed medical therapy and other essential elements of heart failure management. So truly, this is our responsibility as a clinician community to have this realistic discussion with our patients, not to scare them, rather than to educate them about the correct incidence, mortality, and morbidity of heart failure. Now we will focus on the second part of this talk, that is 2022 SEC, AHA, and HFSA guidelines for heart failure management. As I have already highlighted that in this section, we will talk about heart failure management, both inpatient and outpatient setting. Along with this subsection, we will also solve some clinical cases, which we see almost in a daily basis. So why this guideline? Truly, why we are spending our so much important time, energy, attention behind this guideline? Because guideline is a reliable source for clinician community because it incorporate the evidence-based cutting-edge guideline for our daily practice. So this is a reliable tool for us to ensure the high quality of care for our heart failure patients. The guideline is almost 150 pages. So do not worry, I will not go ahead with this on 50 pages. The goal is to focus on what are the important and new, truly what we need to know as a physician to treat our heart failure patients. The guideline is very helpful here to stage the heart failure. For stage 1, this is simply at risk of heart failure. So patients who are simply at high risk because of risk factor like hypertension, diabetes. Second stage is stage B or pre-heart failure. Important to notice that these patients are not symptomatic. However, they have at least one evidence of structural heart disease or risk factor. They are at the stage of pre-heart failure. The third category is stage C or symptomatic heart failure. And the final, it comes with stage D or advanced heart failure. As frontline physicians, this is our onus to make sure that our stage C or symptomatic heart failure patients, they are getting all the evidence-based therapy so that those patients are not progressing to a stage D or advanced heart failure. The stage C or symptomatic heart failure, the trajectory is divided in first at new onset or de novo heart failure. Secondly, resolution of symptoms. Here to notice that they are telling it in heart failure in remission. Thirdly, this is persistent, where the patients are still having ongoing symptoms, sign, and importantly, limited functional capacity. And the last group is worsening heart failure with sign symptoms and also functional capability. Heart failure is still remain clinical diagnosis. We all know that this is a complex clinical syndrome. History, physical goes a long way to diagnose the heart failure. Along with that, we also need natriuretic peptide and transthoracic echo as needed. After the heart failure diagnosis has been confirmed, it is critically important to determine the cause and classify it according to EF. Secondly, evaluate for precipitating factor. Thirdly, definitely we have to focus on initiate treatment. And final point, I would like to bring your attention here that the guideline is now stressing about the importance of serial heart failure assessment. There was an era when I was the resident, or maybe, when I was medical student, it was kind of expected that, okay, we will see the patient maybe in few months, and gradually we will optimize the treatment and assess. In contrast, now the most recent evidence guideline is recommending to have close follow-up and serial heart failure assessment. We will now focus on classification of heart failure according to ejection fraction. The first group come with heart failure with reduced EF, EF less than or equal to 40%. The second group here is mildly reduced, that is EF 41 to 49%. The third group is preserved EF, that we used to tell it as diastolic dysfunction. Now it is known as preserved EF or HFpEF, where the EF will be more than or equal to 50%. The last group is heart failure with improved ejection fraction, where the baseline EF was less than or equal to 40%, and now it has been improved. Worth to remember that they are not calling it as recovered EF. Instead, they are telling it as improved EF, meaning when the patient is having heart failure and now their EF got better, doesn't mean that their heart failure is gone. It means that it has become improved, but not recovered. So we have to be mindful about this terminology. First, we will now focus on truly the biggest bucket of heart failure classification, that is heart failure with reduced EF, which is classified as EF less than or equal to 40%. The current guideline is still telling that diuresis for decongestion, that is the foundational therapy. I would like to bring your attention on this quadruple therapy, that is now the 4 essential pillar of heart failure with reduced EF management, that is ARNI, ACE or R, secondly, beta blockers, thirdly, MRA, mineralocorticoid receptor antagonist, and fourthly, SGLT2 inhibitors. Now, the second category, we have mildly reduced EF, that is 41 to 49%, almost similar as reduced EF, like diuretics as needed. And here, for this category, SGLT2 inhibitor, this is the new recommendation. Now, this is recommended as 2A recommendation for this classification of heart failure. And then for 2B recommendation is ACE inhibitor ARB or ARNI, MRA, and evidence-based beta blocker for heart failure with mildly reduced EF. So before we explore all the 4 essential pillars of GDMT or quadruple therapy, let's focus on case that most likely we have did it very regular basis in our hospital or in our office. So for this first case, this is a 70-year-old woman, is evaluated for 3-month history of heart failure with reduced EF. Her EF is 20%. She has a stable dyspnea when walking up stairs, but has no other symptoms. Her medical history is otherwise unremarkable. She is on valsartan sacubitril, carvedilol, furosemide, empagliflozin, and spironolactone. Carvedilol is at half maximum doses. All other medications are at maximum recommended doses. On physical exam, blood pressure is 118/74, pulse rate 88, BMI 27, which is unchanged from last visit. Central venous pressure and remainder of the examination are normal. So the question is, which of the following is the most appropriate treatment for this patient? Number 1, add ivabrantin. Second, decrease sacubitril valsartan. Thirdly, increased carvedilol, or fourthly, increased furosemide. So we will take around 30 seconds to think about that how would you manage this patient in real life, and then we will move ahead with the right answer and then focus on the 4 essential pillars of guideline-directed medical therapy. If you are interested, if you would like to, share the answer or put your answer in the chat, that will be truly appreciated. Dr. Chaudhary, if anybody is, writing the answer in the chat, please let me know. It's not very much easily visible for me.
Yeah, we've got a couple of responses. Looks like option 3 has been chosen as the most common answer.
Fantastic. Thank you so much, Dr. Chaudhary. Yes, so you are absolutely right. So this is the right answer. So that being said, let's focus on beta blocker. That is one of the essential pillars of guideline-directed medical therapy. We know that one of the 3 beta blockers that reduce mortality and hospitalization, those are bisoprolol, carvedilol, and metoprolol succinate. One of the important point we must be vigilant that sometimes I see that patients are on atenolol, but they have heart failure with reduced EF. So for those patients, we must be vigilant to include them either any of these 3 beta blocker, which reduce mortality and hospitalization. So let's learn some key point of our first clinical case. So you are right, we must have to titrate the beta blocker dose over weeks until the patient achieve the guideline-directed target dose or maximum tolerable doses. So that was the right answer. What about the other options of that question? One of the options they had ivabrantin. So ivabrantin reduced hospitalization in patients with functional class 3 to class 4. We must have to remember that to add ivabrantin, patient must be on maximally tolerated beta blocker therapy. Our patient, she was not on maximally tolerated beta blocker therapy. So that should be the first step. What about Lasix's other option? She did not have any evidence of volume overload, like no JVD, no lake edema, no crackle. So there was no clinical indication to increase the Lasix dose. I truly want to appreciate all of you for your participation in this clinical case solving. Now let's focus on the another pillar of quadruple therapy, that is angiotensin receptor neprilysin inhibitors or ARNI. We know that BNP is falsely elevated in patients when they are on ARNI. So we must have to measure NT-proBNP if the patients are on these medications. Good to know that there is no increased hyperkalemia risk when we use it compared to ACE inhibitor or ARB. There is no difference in the incidence of elevated serum creatinine for ARNI compared to ACE inhibitor and ARBs. For this point, I would like to draw your attention on a meta-analysis where it showed that truly ARNI was associated with less increase in serum creatinine compared to ACE inhibitor or ARB. So at least we can remember that, okay, it's not at the risk of higher increase in creatinine compared to ACE or ARB. However, important to remember that ARNI can cause more hypotension than ACE inhibitors because there are two vasodilators in ARNI. The question is, does neprilysin inhibitor work alone? The answer, unfortunately, it does not work alone because, as you can see, it can increase adverse remodeling as well as angioedema. And that's the reason we use neprilysin inhibitor along with ARB. Couple of key points to remember about neprilysin, about the ARNI, that the evidence has been shown that it reduces mortality and morbidity. Important to remember that already we may have patients who are tolerating well ACE or ARB. Even for those patients, guideline is very, very clear and truly emphasizing to replace them on ARNI because it has been shown to further reduction of mortality and morbidity. So when we are transitioning from ARNI to ACE inhibitor, we must have to remember that there should be at least 36 hours of gap when we are transitioning from ACE to ARNI. For ARB, it's not necessary because patient will be already on part of ARB when they are on ARNI. To make it much simpler for patient, easy to remember, I just tell them 2 days, it's like 48 hours. It's also peace of my mind and to make sure that, okay, there is adequate gap between the ACE inhibitor and initiation of ARNI. So what are the cautionary tale about ARNI? We must have to remember that ARNI should not be administered to patients with any history of angioedema. And also, if the patient has angioedema due to ACE inhibitor, we must not use ARNI for those patients. Now we will focus on our second clinical case. So let's see, what is this patient presenting us today? This is a 49-year-old man who evaluated for management of heart failure with reduced EF. He has EF 30%. He also has atrial fibrillation diagnosed 2 years ago. He has New York Heart Association functional class 3 symptoms and has been stable for the past year. He had ACE inhibitor-induced angioedema, spironolactone-induced gynecomastia. An implantable cardioverter defibrillator is in place. He is on losartan, carvedilol, empagliflozin, furosemide, and Eliquis. So on physical examination, blood pressure is 120/68, pulse is 78 and irregular. We know that he has AFib. Other than an irregular heart rhythm, the remainder of the examination is normal. Serum creatinine and electrolyte are also unremarkable. The question is, which of the following is the most appropriate treatment? Add eplerenone, add ivabrantin, switch carvedilol to metoprolol succinate, or switch losartan to valsartan sacubitril. So for making things much convenient, I am happy to go back to the question so that it will be easier for you to remember what was the case scenario for this patient. Similarly, for previous case, if you kindly share your response in the chat, that will be highly appreciated. Dr. Chaudhary, did we get any response in the chat, please?
So far, we have one response as option 1.
Okay,
As a-
thank you.
Yeah.
Okay, so for purpose of this, time constraint, we will move ahead. And thank you for participating in this response. So the right answer is A. So let's see what is that. So this question highlight another essential pillar of quadruple therapy, that is mineralocorticoid receptor antagonist or MRA. For patients with heart failure with reduced EF and in NYHA class 2 to 4, mineralocorticoid receptor antagonist, spironolactone or eplerenone, is recommended to reduce mortality and morbidity. Extremely important to remember that we must be carefully monitoring the potassium level and renal function when we are starting this medication, as well as thereafter, to make sure to minimize the risk of hyperkalemia and renal insufficiency. Now let's go back to the key point of our second clinical case. Eplerenone is a more selective aldosterone antagonist than spironolactone. We know that it is associated with reduced incidence of gynecomastia. And this patient already had gynecomastia, so that was the best bet to ensure the evidence-based GDMT for this patient. What about the other option? Ivabrantin is not the right option in this scenario because it can increase the risk of atrial fibrillation, and this patient already has AFib. What about switching from carvedilol to metoprolol succinate? Truly, unless the patient do not have any trouble to adhere with the twice daily dose with carvedilol, there is no evidence-based indication to switch it to one way to other, because carvedilol, metoprolol succinate, bisoprolol, all of them reduce mortality and morbidity. So there is no benefit shown other way to switch it back. What about the other option, valsartan sacubitril? Patient should not be on that because we know that our patient had angioedema from ACE inhibitor use. Very important to remember that if the patient is not able to maintain potassium level less than 5.5, guidelines recommend to discontinue mineralocorticoid receptor antagonist to make sure there is no life-threatening hyperkalemia. Sodium glucose cotransporter 2, SGLT2 inhibitor, it is highly recommended that patient who has heart failure with reduced EF, SGLT2 inhibitor are recommended to reduce hospitalization and mortality, irrespective of the presence of type 2 diabetes. So irrespective of the diabetes, patient must be on SGLT2 inhibitor if they have heart failure with reduced EF or mildly reduced EF. Cautionary tale: do not use SGLT2 inhibitors for type 1 diabetes because we know that it increased the risk of DKA. What about diuretics? As always, diuretics is still recommended to relieve congestion, improve symptoms, and to prevent worsening of heart failure. Important to remember that it does not reduce hospitalization or also does not reduce mortality. But for our patients, quality of life, improvement of symptoms, relief congestion is very, very important. For patients who has congestive symptoms, even on moderate or high dose loop diuretics, it is recommended to use the addition of thiazide or metolazone to relieve that congestive symptoms. I always had this question, okay, so I'm giving diuretics, which one to do that? Furosemide, torsemide? Everybody has their own agenda. Thankfully, now we have data about the effect of torsemide versus furosemide after discharge on all-cause mortality in hospitalized patient. This is a Transform HF trial that came last year. And the bottom line of this study that was published in JAMA, it showed that among patients discharged after hospitalization for heart failure, torsemide versus furosemide did not result in a significant difference in all-cause mortality over 1 year. I would like to draw your attention on a couple of selective additional medical therapies, definitely after optimizing guideline-directed medical therapy. One is ivabradine, and ivabradine has 2A recommendation. So this is recommended for patients who have EF less than 35%, always on normal sinus rhythm, very important to remember, with heart rate of more than or equal to 70 at rest. And again, highly stressed that patient must be on maximally tolerated beta blockers. What about digoxins? We know that this is an old drug and is still on the market. So which patients will be candidate for digoxin after optimizing GDMT? If the patient still has symptomatic heart failure despite GDMT or unable to tolerate GDMT, it has been shown to reduce hospitalization for heart failure, but not mortality, according to current evidence. Now let's switch our gear on heart failure with preserved ejection fraction, that is EF more than or equal to 50%. And it is worth to notice that over the years, the incidence of heart failure with preserved EF has increased. For many, many years, heart failure with preserved EF remained unknown territory because we had very less evidence, very less data, and truly we did not know how to treat this part of heart failure. Fortunately, we have little bit more data than before. So this guideline support the evidence of treatment of heart failure with preserved EF, first with diuretics as needed, and it has 2A recommendation for SGLT2 inhibitor. For ARNI, MRA, ARB, it has 2B recommendations. I would like to draw your attention here that beta blocker is not included in this treatment regimen for preserved EF, who is more than or equal to 50%, because the patient who has preserved EF, they have fixed stroke volume, and they truly depend on heart rate. So we have to be very mindful before placing beta blocker on these patients unless they need it for rate control for AFib. Even though we must be very cautious about adding beta blocker for the patient who has heart failure with preserved EF. Last year, fortunately, 2023, SSC had expert consensus decision pathway about this long ignored but significantly important classification of heart failure for preserved EF. So let's learn few key points from this consensus. First and foremost, we know that for heart failure with preserved EF, we must prioritize managing the comorbidities such as hypertension, diabetes, obesity, atrial fibrillation, and sleep apnea. We have just discussed that for preserved EF, it is 2A recommendation to add SGLT2 inhibitors for all heart failure with preserved EF patients. Worth to notice that natriuretic peptide are lower in obese individuals with HFpEF. We know that it is lower in obese individuals. However, when the patient has obesity, also heart failure with preserved EF, the natriuretic peptide is much lower for these patients. So we must be clinically vigilant when any obese patient is coming with HFpEF. Women with HFpEF have more dyspnea and has worse health status according to the 2023 updated consensus pathway. The million-dollar question is, can we save lives by evidence-based, guideline-directed medical therapy? Because, at the end of the day, our goal is to saving lives and making difference for our patients. The answer is yes, we save lives by GDMT. And this study was published in Lancet, where they found out that when patients are on all the 4 essential pillars of GDMT, it increased 8 additional years free from the cardiovascular death and heart failure hospitalization. Also, we were able to add 6 additional years of overall survival. We have learned so much benefit of GDMT, but is this for everybody? The answer is no. Particularly when a patient is pregnant and has heart failure, we must be vigilant that ACE, ARB, ARNI, MRA, SGLT2 inhibitor, ivabrantin must be avoided. It is contraindicated because of significant risk of fetal harm. I'm a big believer of this quote of Sir William Osler that the person, when they take medicine, truly we must have to recover twice, one from disease, one from the medicine. Although we know that, okay, GDMT save lives, the reality is all of these has side effects. So what else we can do to make sure that, okay, patients are not on unnecessary medication, and most importantly, they are not on harmful medications. So one point to remember that for patients who have HFrEF or reduced heart failure, reduced EF heart failure, they must not be on non-dihydropyridine calcium channel blocker. So if the patient are on that, as soon as they are diagnosed with heart failure with reduced ejection fraction, we must have to discontinue those drugs such as verapamil, diltiazem. NSAIDs. Heart failure patients, they have some joint pain, they have some this kind of pain. Here and there, they're taking so many NSAIDs, which is a very much overlooked territory of precipitating factor of heart failure, morbidity, and hospitalization. So if the patients are on heart failure, if the patient has diagnosis of heart failure with reduced EF, and if they're taking on NSAIDs, it's very, very important to tell them that, okay, it can worsen the heart failure symptoms, and try to minimize the NSAIDs and try to find out other alternative for their pain control. Thiazolidinedione, pioglitazone, rosiglitazone, that can also increase the risk of worsening heart failure symptoms as well as hospitalization. So we must discontinue these medications for our heart failure patients. What about DDP4 inhibitors such as saxagliptin? For heart failure patients, DDP4 inhibitors can increase their heart failure hospitalization and must be avoided for heart failure patients. This is a very important aspect of current guideline, and that I truly appreciate that it gives us some guidance that, okay, what to do for patients whose EF has recovered. The guideline is very, very clear about it, that heart failure with improved ejection fraction, even if they are completely asymptomatic, they are feeling the greatest of their lifetime, we must have to continue the guideline-directed medical therapy to prevent the relapse of heart failure as well as LV dysfunction. Because This was published in Lancet in 2019, and it showed that when the patients were taking off from GDMT, shockingly, 50% of the patient relapsed within 6 months. So one of the key takeaway I want to take from this talk that even if the patient has recovered EF, we must have to continue the GDMT. One of the question I always had that, okay, how often we should titrate this evidence-based guideline-directed medical therapy? And fortunately, the current evidence is recommending that we should titrate all these guideline-directed medical therapy every 1 to 2 weeks, depending on patient symptoms, vital signs, and laboratory findings. I know that these guidelines are important, but at the same time, as clinicians, we are the front line of treating our patients. Patients do not read guideline. If the patient is not suitable enough or not safe enough to titrate GDMT, then we have to focus on the patient-specific situation rather than solely on the guidelines. Now let's shift our gear on the hospitalized patient with decompensated heart failure. As soon as we see the patient in hospital, we have to identify that what could be the precipitating factor, how severe is the congestion, and then optimize the volume status, address the reversible factor, and very importantly, continue or initiate the GDMT. So this 2022 guideline is having a couple of key points that I would like to address here for hospitalized patient. First of all, if the patient has heart failure with reduced EF, GDMT should be initiated during hospitalization, importantly, after clinical stability. And we have a strong data that shows that when GDMT has been started in hospital compared to as outpatient, the adherence is much higher when they are started during the hospitalization. For some reason, if it is clinically indicated, if that GDMT was discontinued, it should be reinitiated and further optimized as soon as possible. Very importantly, that we must have to follow up this patient within 7 days of hospital discharge. There was one era, not many years ago, that when we used to see our heart failure patients in every few months. But now this is highly recommended that we must see our heart failure patients after discharge within 7 days because it reduces hospitalization. We all know that there is a real-world barrier of GDMT. It does not matter how much they are effective to reduce mortality, morbidity, and hospitalization. Not only at the patient level, maybe high cost, old age, frailty, also on the part of clinician as well as system-wise. So what else we can do beyond GDMT, truly at our patient level, to optimize the heart failure management? First and foremost, we must have to remember that regardless what is included in the guideline, heart failure management, this is a comprehensive team effort. Heart failure management is much, much more than only GDMT. So this is a patient-centered care where doctor and patient, they are truly the team member. One of the important points here I would like to emphasize that we must be attentive to review our medication list to avoid polypharmacy, because many times patients are maybe building up medication over time. So we need to be very cautious to make sure that our patients are on the therapy what they needed, not only unnecessary medications that may be not adding any value, or sometimes maybe truly worsening, could be causing the precipitating factor of heart failure exacerbation and hospitalization. So we will focus on a couple of very common comorbidities of heart failure patients. Almost 50% of the symptomatic heart failure patient has iron deficiency anemia. And sleep disorder breathing is nearly prevalent about 60% of heart failure with reduced EF patients. So this guideline is recommending to have IV iron replacement therapy for heart failure with reduced EF with or without anemia if they have iron deficiency, because it improves functional status and quality of life. Worth to notice that it is against the recommendation to use any erythropoietin stimulating agent for any heart failure with anemic patients. What about hypertension? If they have hypertension, heart failure, we should up-titrate the GDMT to adequately control that blood pressure. What about sleep disordered breathing? It is highly recommended to do sleep assessment to differentiate whether the patient has central sleep apnea or obstructive sleep apnea. We know that obstructive sleep apnea is many times is that hidden killer that can trigger not only the heart failure, also atrial fibrillation and also other comorbidities. So it is very important to have formal assessment, and if they have obstructive sleep apnea, they should be on CPAP. What about diabetes? We know that most of the time diabetes, heart failure kind of go hand in hand. So if they have diabetes, it is highly recommended to start SGLT2 inhibitor to reduce heart failure related mortality and morbidity along with management of hyperglycemia. For atrial fibrillation, it is highly recommended to use that chronic anticoagulation if that CHA2DS2-VASc score meet, and also DOAC is now highly recommended over warfarin. At the same time, I understand that not only in Bangladesh, sometimes in the US too, that patient has unique circumstances that, okay, they are more comfortable with warfarin. So that it comes about shared decision making and truly, focusing on that patient rather than focusing on solely guidelines. Years after years, my attending physicians and me, we are always telling our residents, our medical students, our patients that, okay, be cautious about fluid restriction, you have heart failure. The question is, how much evidence do we have? There was a meta-analysis done of 6 randomized control trial. There they compared both liberal and restricted fluid intake. And it was very eye-opening for me to see that they did not find any difference in mortality as well as heart failure hospitalization between liberal and restricted fluid intake. There was no difference as well in duration of IV diuretics. So what is the guideline is telling? They are very upfront that we do not have enough data about the benefit of fluid restriction to reduce congestive symptom for heart failure patients. What about salt? We know that we use so many food and maybe sometimes we do not pay that much attention about the high salt content. Those who are, very much fond about this, shutki mach, I never realized that, okay, how much salt is in there. Not only all these dried food, canned food, pizza, a lot of fast food has high salt content. And we are always telling our patients, okay, watch your salt. The question is, how much evidence do we have on the salt? This paper was published in Lancet, and the trial is sodium HF. The bottom line of this trial is that low sodium diet was not associated with a reduction in adverse cardiovascular events. It was associated with modest improvement in quality of life. So the guideline is recommending for stage C or symptomatic heart failure patients, avoiding excessive sodium intake is reasonable to reduce congestive systems. Patient education. I believe this is, crucial part of not only heart failure for any disease management. This is our onus to educate our patient and their family not only about the benefits, also the side effects of all the guideline-directed medical therapy. And very importantly, discourage them to self-decrease and discontinuation of medications. I know that, for many of my even relatives, it is highly prevalent that, okay, as soon as they feel better, they want to stop that medication. They do not even think that, okay, they maybe need to talk to their physician. So it is crucially important for us to educate our patients, their families, that they must not discontinue or decrease the dose of these essential medications. So this is my final slide. I would like to end this talk with these top 5 key takeaways. First and foremost, we know that quadruple therapy, ARNI or S or ARF, mineralocorticoid receptor antagonist, beta blocker, and SGLT2 inhibitors are foundational therapy for heart failure with reduced EF patient. Secondly, SGLT2 inhibitors can be beneficial in decreasing mortality and heart failure hospitalization. Thirdly, treat comorbidities that can worsen heart failure, such as hypertension, sleep disorder, anemia, diabetes. Fourthly, initiation and most importantly, titration, optimization of quadruple therapy in heart failure with reduced EF is critically important. We are not in that era that, okay, we will take our time, gradually optimize. Now, this is highly recommend to start all of them together if the patient can tolerate, or have a mindset to optimize within 1 to 2 weeks. So close follow-up is absolutely critical. And for fifth point, I would like to highlight that in patients with heart failure with improved ejection fraction, if they are completely asymptomatic, we must continue GDMT to prevent relapse of heart failure. I sincerely appreciate all of your valuable time and attention to this talk, and thank you so much for this invitation. I would like to turn this over to Dr. Chaudhary now, and I look forward to have Q&A session to interact with all of you. Thank you so much.
Well, no, thank you, Dr. Hawk. That was a very articulated and detailed talk on a topic that is simultaneously something we do every day, but also difficult to navigate through. I think your last slide summarizes the major points brilliantly. This is heart failure, as we know, is a joint venture. Internal medicine doctors with our subspecialty cardiology colleagues, we're in this together. And the communication between subspecialties when it comes to managing a patient with heart failure becomes very, very important. I think you touched on it superbly. I think as internal medicine doctors, myself and yourself included, and the trainees that are listening, it is very important to have the basics understandings under control before we seek help from our ever-busy cardiology colleagues. And in that light, this talk was actually on point. A lot of stuff that you mentioned is something we try to hammer into our residents and interns, because unfortunately, some of the settings we practice in, the onus often is, oh, it's a heart failure patient, let's talk to cardiology. No, let's do what we can do based on the knowledge we have, and then talk to our colleagues, because they are already as busy as it is. And in an outpatient setting, a lot of times access to subspecialty is a problem, especially in some areas of the United States even, and of course in Bangladesh. So we have to be able to manage basic heart failure patients, and in conjunction with our cardiology colleagues. So from that aspect, your talk was brilliant. It is a very timely topic. We do know that, at least my data is from American census and American studies. We know how much it costs CMS, Medicare and Medicaid, to take care of heart failure patients, and how much of a room there is for us as physicians to improve on our care delivery model so we can reduce comorbidities and mortalities from heart failure. So thank you for that talk. We have a few questions that I would like to present. One of the questions that was asked was, is it important to classify heart failure with mildly reduced ejection fraction? Is the management of heart failure with mildly reduced ejection fraction different from heart failure with reduced ejection fraction? So,
Wonderful. Dr. Choudhury, do you want me to address, or do you want to go to our brilliant panelist? It's
I
your
think
choice.
I will open it up to all our panelists and including you. Anyone who wants to take this question is appreciated. We do not have many questions, so anyone's who wants to share their input will be much appreciated.
Yeah, I can jump in, and
Sure.
then I would be very much open to our brilliant panelist input as well. So guideline is recommending to have the same treatment for between mildly reduced and reduced. Definitely that comes with diuretics for decongestion, and then 4 essential pillar, that is like ARNI, S or ARB, beta blocker, MRA, and SGLT2 inhibitor for both mildly reduced as well as reduced ejection fraction.
I think
Great.
there's a plethora of studies looking at this particular group with mildly reduced EF. The problem is that we do not know the natural history of this group, whether they will be going further downhill with reduced EF, or they may get better and behave like a preserved EF. But if you ask me the question about therapy, then we actually are obligated to give the decongestion drugs, which have no survival benefit, and then institute the therapy that we heard is the neuromodulation or the neurohormonal modulation. Because still, if you look at this heart failure business, that it is ultimately the pump. However, anything that we do for whipping the horse gets tired, and no inotrope has shown any survival benefit. And then the initial appreciation of congestion in early 60s, late 60s, with diuretics only, we have symptoms improvement, but no survival benefit. The only thing that has shown survival benefit is something that helps the neurohormonal activation pathway. And we now have 4, and maybe you can call it 5 pathways that we heard elaborately that can help the survival, which is the key. So that's my comment. But I think I would also make this comment that heart failure is sometimes can be, or many times can be like a fever. You really need to address the underlying pathophysiologic mechanism. Heart failure is not just a wholesale diagnosis. You have to elaborate further that this is a systolic, diastolic, and many of the systolic we know has mixed systolic diastolic dysfunction. But then etiology, etiopathology is very important in terms of basic cardiomyopathy, or is it ischemic, non-ischemic cardiomyopathy, if there are risk factors. And I'm not going to go into the details because it varies in terms of managements, the logistics and the challenges. We have remote areas where we can have this tincture of time, start guidelines directed therapy and see the heart failure get better. Or sometimes, if you have all the resources, you immediately go in a reduced EF, whether this is ischemic or non-ischemic. Importantly, also important to know whether there is any associated valve disease, etc. However, I would also point out that in a small cohort, maybe it may be a mimics of heart failure. For example, constrictive pericarditis or bad cardiomyopathy, such as restrictive cardiomyopathy. But vast majority, we will be able to figure out what is the underlying etiopathology of heart failure. But brilliant things that added, and I congratulate you that it is very emotional to me that sometimes we overdo things. We leave the patients with a miserable life, like restrict fluid, like 1 liter, then avoid salts, like all that. This is very important because heart failure is a chronic disease, and we don't want to make the life of our patients miserable. But very well done. Thank you.
Thank you, Dr.
Thank you, Dr.
Hassan.
Chaudhary. Very
And
beautifully
we have,
said.
go ahead, Dr. Haq. Yeah, go ahead.
Yeah, I would like to appreciate Dr. Chaudhary's comment. Definitely, that was so many learning points for me. And in this platform, I would like to share my sincere gratitude to him because over the years I have learned so many things from his talk. So I'm so much thankful for all his expertise, and he always take time to teach us. Truly appreciating.
No, thank you, Dr. Hassan. Appreciate your opinion. And we actually have another question, which I think pertains to practice here a lot, which is, and I get a question a lot from the residents as well, which is if somebody who hasn't been tried on this, should we start SGLT2 before discharge in all HFrEF patients in case there's no contraindication?
Very good question. And the shortest answer is yes, because we have evidence that it reduces mortality, morbidity, hospitalization, and if there is no contraindication, we must start it. The second point I would like to highlight here that there is a strong data that when physicians start any new drugs in the hospital setting, the patient are more inclined to take it. The adherence is much more compared to when the medications are started in outpatient. So if there is no contraindication, we must start it. Sometimes, there could be some situation in the hospital that it's not possible to start. In that situation, our goal should be optimize it at outpatient. Thank you.
And
Thank
I would
you.
add, this is a big yes. And for all the reasons you said, and Greg Fonerov from UCLA has shown, when you start it, adherence is high, and when the adherence is high, the outcome is better. So, Adnan, where are you located?
I'm located in Kansas City
I see.
at University Health.
Yeah.
Thank you so much for the input. I have a question for Dr. Rafiq Islam. There's a bunch of questions, but for the sake of time, I think I'm trying to do important ones. So the question has been, if in Bangladesh or even in America, why heart failure with preserved ejection fraction incidence is increasing? If you could shed some light on that, are we seeing that also in Bangladesh as well?
Yes, actually, we are facing this problem in Bangladesh. Thank you, Dr. Adnan. I think that was previously called the diastolic heart failure so far. I am an internist, not a cardiologist, but we think that in Bangladesh, hypertension is not properly controlled. People are not taking the antihypertensive medication regularly. They take the medication only for 7 days, 10 days, or 15 days as the prescription writes it that continue the medication, but they take the medication only for few days or as few days as he can, like 1 month, 2 months, but they do not continue it. And there is a aphorism in Bangladesh: if you continue medication, you have to continue for lifelong. So omit the drug. So maximum people omit the drug, and by this time they get the concentric hypertrophy of the ventricle. And that causes this sorts of problem, I think.
Thank you. I think so. From my personal experience in Bangladesh with relatives and few people I've heard of, I think that's very common that we tend to think of antihypertensive medications as like antibiotic. Oh, if I feel better, I should stop taking it.
Absolutely.
And that plays a role. Which I learned myself from talks here, that our food has a lot more salt. In America, at least we can read the package and see salt, and maybe salt plays a role in onset of earlier diastolic hypertension as well. I know there has been some studies on that. And we don't go to primary care doctors as often as we do in first world countries. So sometimes hypertension takes longer to diagnose. And maybe by that time, some damage is done, and that contributes to this HFpEF incidence.
Absolutely.
Yes. And then we have another question that's I'll open up to the panel, which is, I mean, we also deal with it as internists, is there any significant difference in managing heart failure exacerbation in in a clinic setting, sorry, in an inpatient setting when you have patients having CKD. How do we change our approach at that point if there's CKD?
So it's to me.
To anyone, yes, Dr. Rafiq, if you want
Yes,
to take it, that's fine. Yes,
it's a
please.
it's a very difficult question actually. In the CKD patient, hypertension is a very difficult to manage actually. Many time we use the multiple medication to control the hypertension, and if you cannot control the hypertension, you cannot control the heart failure. There is the hypertension heart failure. This is another entity. So we try to control the hypertension by the ACE inhibitor, or I'm checking the creatine clearance, as well as prazosin is the premier drug actually to control the hypertension in case of CKD, as well as calcium channel blocker we try to use. But controlling the same time the heart failure is a very difficult, and we use diuretics firstly, and it's a simply we don't use any it's a 4 pillar actually. We use your diuretics, ACE inhibitor, and the control of premier thing is to control the hypertension. And that's how we actually manage the CKD patient with heart failure. So what is your opinion actually, how you manage CKD patient with uncontrolled hypertension with heart failure?
Yeah, it's always it's one of those tricky situations, and obviously it matters what stage of CKD patients are in. Unfortunately, once they approach CKD stage 4 to 5 and is becoming anuric, it becomes really difficult at that point to our choices of medications are obviously getting reduced. So for me, it's always been a spectrum. The easiest patients, if I can use the word easy to manage, is CKD stage 1 to 2, where they're producing urine, and I can use pretty much almost all the drugs cautiously and manage this. But as they progress, it really becomes difficult for us. Sometimes obviously it's a shared decision making in America, so we have to make the patients aware that what we're doing can actually harm their kidneys. And I am very candid and upfront with them that I will temporarily have to sacrifice your kidneys to basically get you through this difficult heart failure exacerbation. And once we make that decision, we go forward. And obviously, sometimes it works out fine and sometimes it doesn't work out. And then we go to the next step. Obviously, cardiorenal syndrome complicates things as well, and that's beyond the scope of this talk. But that's what we try to do. I try always to treat patients, as they present rather than just numbers, as long as we are working as a team, because there is no right or wrong answer when it comes to CKD and heart failure. We have to sacrifice one or the other, and we are always stuck between a rock and a hard place. So yes, medicine choices are limited, to summarize the answer, but whatever I can use, I try to use to get them over the hump. And then aggressively managing modifiable risk factors, lifestyle changes, weight loss, glycemic control, what have you. So
One,
please.
yes.
There is one right and wrong answer I will say for Bangladesh. One is that please try not to admit the patient, please, because hospital is a bad place. It has cost implications, and recurrent hospitalization has even prognostic implications. So try not to admit. And then this cardiorenal, the renal guys will tell you type 1, 2, 3, 4, 5, but I don't really care, because you need to make sure that the kidney is working with producing urine. If the urine is not coming out, we are in a bad place. And you also need to exclude whether there is an intrinsic renal disease and obstructive uropathy. Because if the kidney is bad, then we are really in a bad place. after heart, I love the organ kidney. So it is very, it is very, very important because, and then, which was not the scope of today's session, that soon the patient may succumb to refractory heart failure, which is really a different topic altogether. But, but I think we also need to be careful about diuretic use and probably use the sequential blockade so that we can get enough diuresis, but that it can be a fine line. But please try to, I will tell anybody hearing this talk, try to avoid hospitalization. Hospital is a bad place.
Actually, in Bangladesh, what we are learning here is the 4 pillar of fantastic 4 or 4 pillars of heart failure in case of reduced ejection fraction. But what is the situation in Bangladesh? We are learning this from the journals from USA and from the Western countries. But what is the situation in a poor country like Bangladesh? Is it affordable for empagliflozin for every patient? It's not so. Can we afford the ARNI to every patient? No, it's impossible. This is a very costly medication. So after getting the patient, actually nearly 10 to 20 patients we get in each admission. I got 150 patients in each admission, 24-hour admission in my unit. So in every day, every admission, I get at least 20 patients of heart failure. So can and for each patient, if I want to check the echocardiography, I should have to take at least 5 working days to get an echocardiography. So I take the old method, check the patient has having the gallop rhythm, patient having any bivasal crepitation, whether it's a right-sided patient having HEAP or any palpable P2, JBP, and enlarged liver. So check what is the situation of the patient and start with the diuretics to decongestion of the patient. That is the first pointer. And if the patient is affluent, try to start the ARNI. And if the patient is not, maximum patient cannot afford ARNI and government is not providing them any ARNI or any SGLT. So government is providing beta blocker, but not the that is a beta blocker, that is carvedilol, bisoprolol, or metoprolol. Here in Bangladesh, we have metoprolol tartrate, not succinate. That is you have to take multiple times. So we can use the AC inhibitor, the losartan potassium, what is available in Bangladesh. You start the losartan potassium, then eventually after a few days we can start the beta blocker. That's what the approach we are taking. But there are some affluent patients also. We can use those 4 pillars in those patients. So it's a very difficult in Bangladesh. What we are learning in a seminar or in a webinar. But it's also important. It's also important for us because we have to be internationalized and we have to accommodate all the knowledges from the Western society. And we have to applicable it in our society, but it's very difficult.
তোমাকে দেখে মনে হচ্ছে আমার থেকে বয়সে কম হবে তোমার, তো তুমি যা বলতেছো তা মানে is like music to my ears, and this is like master talking. I really appreciate. Are you using point of care ultrasound?
Actually, বাংলাদেশে কোথাও পয়েন্ট অফ কেয়ার আল্ট্রাসাউন্ড এখনো ইন্টারন্যাশনাল ব্যবহার করে না। তবে আমি নিজের তরফ থেকে আমি একটা পয়েন্ট অফ কেয়ারের জন্য একটা আল্ট্রাসোনোগ্রাম মেশিন কিনেছি এখন বাংলাদেশি টাকা এটা প্রায় 3,15,000 টাকা। এটা আমার নিজের সেলফ খরচ থেকে কিনেছি। কারণ কিছুদিন আগে আপনার আমাদের যে সোসাইটি অফ মেডিসিন কনফারেন্স হলো সেখানে আপনার নিক মোর্চ এসেছিল, সোসাইটি অফ অ্যাকিউট মেডিসিন ইউকে থেকে। সে আমাকে এসে বলে গেছে তুমি কিভাবে মানে একটা পোকা ছাড়া কিভাবে তুমি ম্যানেজ করো। তো এখন আমি তার সাথে আসলে 3 দিন 4 দিন তো কনফারেন্সে ছিলাম, আরো 3 দিন বিভিন্ন চিটং, সিলেট, কক্সবাজার ঘুরেছি। ঘুরে তার সাথে আমি আসলে আমার ভিউজ গুলো এক্সচেঞ্জ করেছি। আমি মনে হয়েছে যে পোকা ছাড়া আমরা টিকতে পারবো না।
Absolutely.
This is
brilliant. And also you can do dry lab like BNP. Dry lab is also available. But we are, I'll keep in touch with you. This is like really listening to the master. So definitely this is a good avenue to connect.
Absolutely. I'll remain connected with you all.
No, thank you, Dr. Rafiq. For oftentimes here, we forget how lucky we are with resources, but I'm also blessed enough to practice in a safety net hospital. So আপনার যে problem, it's the same thing. My patients cannot afford SGLT2 or
Absolutely.
ARNIs, you know. So we have to manage, but obviously we have more other resources. But thank you for pointing that out. You know, I never practice in Bangladesh, but I think Bangladesh needs to have a public health initiative where we prevent heart failure from getting into that point where our hospitals are not as stressed taking care of heart failure exacerbation patient. And that's again beyond the scope of this discussion. But I always learn joining this discussion, and especially the brilliant minds from Bangladesh and our senior brothers and sisters here who have been practicing medicine in America. I mean, it's brilliant to hear your point of view. So I would love to thank all of you, Dr. Hassan, Dr. Rafiq, Dr. Hawk, for sharing this precious time on a weekend to educate us. I certainly learn a lot and rehash a lot. So without, if there's no more questions, I would again thank you all, and we would close the session. Chandan Bhai, anything else you would like to add?
No, thank you, everyone. As you said, like I was not able to be there all the time. As I said, I was on call, and unfortunately, I have to run away to the ER and see few patients in between. So, so I missed few stuff, but I think the discussion that we had, I think that is one of the goal, how we can learn from each other, right? And some of the challenges that Rafiq Bhai was, Professor Rafiqul Islam was discussing, I think we have the same challenges, though from there it feels like that we have so much resources. But I think challenges are the same. So yes, heart failure, as I think Dr. Farzana Haq at the beginning mentioned, that every time there is a patient who has the diagnosis of cancer, they think about that their clock is ticking. But when you tell them they have a heart failure, they then feel that urgency. But it is true that clock is ticking for them as well. So we need to take care of that heart failure diagnosis very seriously and, you know, like manage accordingly. The good thing is that there are lots of guidelines nowadays that we talk about the 4 pillars of the management. But again, as Professor Islam said, those are the guidelines that was developed based on the data from the Western countries, but not from the Eastern or the Southeastern population, which is totally different. And I know that Adnan is very interested in hypertension and all those diseases. Is the same story, that we always try to treat patient based on the data from the Western countries, but from our own side, I mean, there are limited data. So I feel like that we do have opportunities to, you know, do some research in this area and try to find our own data. I think that will definitely help managing our patients better in that part of the world.
Thank you.
No, thank you, everyone. I think phenomenal
Thank you.
presentations and such a great discussions, everyone. Thank you.
Thank you, Dr. Farzana Haq, for your wonderful presentation. Excellent presentation. Thank you.
Yeah,
Thank
thank
you
you, Dr.
so
Hawk.
much
I
for your
learned-
kind words.
I learned many things.
So, Dr. Rafiqul Islam, I put my phone number in the chat box.
Sure,
Please give me a text. Thanks. Thank you.
sure.
And Dr. Rafiqul Islam, I hear you, and I
Yes.
truly understand that, okay, how much is challenges, because not many years ago I was the intern, and then I had the privilege to practice medicine in Bangladesh. And you know,
Right.
when I go back to my in-laws, that's the reality, because like a significant part of the people, they cannot afford the SGLT2 ARNI, and truly, you know, they do not care about the 4 essential pillar, because if they do not have money for food, why they will care about this 4 essential pillar? So, you know, truly at the end of the day, what we can do, our limited resources, and that's why my kudos to you and all the physicians in Bangladesh who are
Right.
giving like phenomenal care to our patients with the limited resources.
By the way, the local Entresto equivalent drugs are available. These are also much cheaper. It's cheaper, but it's not inexpensive. You can advise, and these medications do work. And there is a website where you can check what is the equivalent in Bangladesh. You can see, and they give you a price list as well.
না, আমাদের এখানে
Good
ড্রাগগুলি
point.
ডেফিনেটলি আপনার বাইরে থেকে অনেক চিপ, কোনো সন্দেহ
হ্যাঁ,
নাই। স্টিল
Still,
it's,
yes,
it's,
yes.
it's not
Yeah.
affordable for many patients. এবং
right.
শুরুতে হয় যেটা কি যে আপনার পেশেন্ট খুব আগ্রহ নিয়ে স্টার্ট করে না আই হ্যাভ টু সার্ভাইভ সো লেটস স্টার্ট কিন্তু আফটার ফিউ ডেজ আপনার দেখা যায় যে আপনার উইদিন কাপল অফ উইকস দেখা যায় যে দে ফিল টায়ার্ড
Yeah.
তারা আর এফোর্ড করতে পারে না।
এটাতে রাজরোগ।
আমি এখানে চ্যাট বক্স আই এম নট গেটিং দ্য চ্যাট বক্স
I think we রফিক ভাই আমি আপনাকে
আপনি আমার নাম্বারটা আহসান ভাইকে
হ্যাঁ
দিয়ে
হ্যাঁ
দিন
হ্যাঁ সেটাই আমি
Please.
বলতে চাচ্ছিলাম যে আমি আপনাদের নাম্বারটা আমি এক্সচেঞ্জ করে দিব।
শিওর
Thank
শিওর
you.
ঠিক আছে,
থ্যাংক ইউ ভেরি মাচ
থ্যাংক ইউ
Thank you,
এভরিওয়ান।
everyone.
থ্যাংক ইউ
Thank you.
Thank you so much,
Chandan, thank
everyone.
you.
Thank you, Dr.
You are
Locke,
the
Thank
and
you.
you are the
Thank you.
master facilitator.
we'll be in touch.
Yes, yes.
Thank you.
Very nice meeting you. Very
Thank
nice
you.
meeting
Sure.
everyone.
Thank you.
থ্যাংক ইউ গুড নাইট ফ্রম বাংলাদেশ
Thank you.
Good night,
Thank you.
everyone.
Thank you so much, Dada.
No, thank you. It was a brilliant presentation. I wish I will try to listen from that Facebook Live. So
That's
yeah,
very
I need
kind of
part
you.
it. No, thank you.
Thank you, Dada. Bye.